A very good evening to all of you present here. Thank you very much for logging in for this first academic meeting of the newly formed SFM Telangana chapter. At the outset, I thank our founder mentor, Professor Ashok Khurana, for the opportunity of making a separate chapter of the SFM Telangana. And I have the privilege of being the president of this chapter, and Dr. Shagun Agarwal is our secretary. And on behalf of all the senior mentors of the SFM Telangana and the entire team of office bearers, I welcome all the senior members of this SFM Central Office. We have Dr. Thelen Praveen, Dr. Bimal Sahani, and Dr. Khurana all here to encourage us. We have Dr. Geeta Kolar and Dr. Narsimha Reddy sir, our senior patrons. And I hope that we will be able to conduct these monthly meetings on a regular basis on the third Wednesday every month on behalf of the SFM Telangana. So at the outset, let me say that this first meeting we have just brought together with the core group, whichever was ready with the topics. But henceforth, I request all of you to get in touch with myself or Dr. Shagun Agarwal with ideas regarding your presentations. And we would like you to present your cases and come up with topics for discussion so that the main aim of SFM Telangana is achieved of bringing out the best of fetal medicine from the state. So once again, thank you very much for all of you being here. And Dr. Khurana, would you like to say a few words as we begin this program?
That's very kind, but right at the outset, congratulations. We have finally got this off the ground. It's never the easiest to get anything new going, and especially when our membership is now becoming so wide across cities, I do hope we're going to be able to be a little more inclusive and make sure that it's not just the metros, but every little place. We have the advantage of having learned that the virtual world is possible, and we can now juggle between the virtual world, the real world, and both of them, what we call the hybrid world. And I think that's going to give us an opportunity for each one of us to reach out to each other, to be of use to each other, to be of use to finally improve what all of us seek to do, which is to improve fetal outcomes and to give each fetus the best that we can give it. So my congratulations for getting together today, and all the best for the future.
Thank you very much, sir. We also have with us Dr. Thelen Praveen, who's been the president of the SFM, the national body, and we look forward to all his blessings while running the state chapter. Sir, could you just tell us a few words before we just start the program? So you need to unmute yourself, sir. No, not yet. Still not, sir.
Okay.
Yeah.
Good evening.
Good evening, sir.
Nice that we have started off and with a very positive note, and then we have wonderful people as our members of Telangana SFM, and I think we are going to do a lot of good work, particularly the academic works, because under your leadership, I think we should be doing pretty many good academic events, and I wish all the best, and we are all together. We will be together. Thank you.
Thank you very much, sir. And we also have Bimal Sahani, sir. He's going to take the first talk. But prior to that, I would like to call upon our chairpersons for the first session, Dr. Geeta Kolar and Dr. A. Narsimha Reddy. So I hand over the session to the chairpersons to introduce this webinar, as well as Dr. Bimal Sahani, and then we'll move on. Geeta ma'am and Narsimha Reddy, sir. Geeta ma'am, you need to unmute yourself.
Good evening.
Good evening, ma'am.
Good evening. Thank you, Dr. Ashok, Dr. Praveen, for this opportunity to kind of meet again on this webinar. So today we've tied up with some interesting sessions, and let me introduce the topic. But Dr. Bimal Sahani, do we have a slide to introduce him, because we all know him?
No, we don't have a slide to introduce him, because I don't think we need to introduce him in. But the one word that I would like to say, whenever I think of him, I think of very simple examples. Somebody who can make a very tough topic so simple and so interesting that you will never forget it. So there are many examples of his which I have stolen in my life. But over to you, Geeta ma'am.
Yeah, thank you. And today we want him to speak to us on fetal cardiac evaluation, new age possibilities, and new age expectations. I'm sure he's going to give us some really new expectations to expect from our cardiac scanning. Over to you, Dr. Vimal.
Thank you, Dr. Kohler, and thank you, Chinmay. Can I share my screen now? Yeah, good evening, everyone. At the onset, hearty congratulations, all the office bearers of the new Telangana chapter. You've, they say better late than never. And so eventually things are on track and this chapter has begun. And I wish you all the best. And we are expecting a whole lot of academics coming from this chapter. And I think, I hope well begun is half done. And I also want to thank you all for giving me the privilege to open the innings in your opening monthly meeting, and really honored for that. Now, my topic is fetal cardiac evaluation, new age possibilities, and new age expectations. I was just saying that Dr. Chinmay has got a habit of giving topics which the faculties have to give some time to think before they start making their talk on that. Now, cardiac evaluation. There was a time we used to say cardiac evaluation, is it so important? But now we don't say, is it so important? We say, why is it so important? Because we all know it is important. Because it has a very high incidence. The prenatal diagnosis of complex CHD at the right time gives the option of termination of pregnancy. Prenatal diagnosis gives the option to deliver in a tertiary center, especially with this ductal dependent lesions where prostaglandin infusion can be given, immediately to maintain the ductal patency. And then now it is proven beyond doubt that postnatal surgical outcomes are far better in prenatally diagnosed cases than those which come as a surprise immediately after birth. Now, as far as cardiac evaluation is concerned, there has been an evolution. There was a time when looking at the heart was just whether the heart is beating or not. Then we reached a stage where we could, grossly say whether the heart appears normal or abnormal. And then a stage came, about 10, 12, 15 years back, where we were closer to a precise diagnosis, or we could give a differential diagnosis. And then the stage was that stage of a precise diagnosis where we could definitely say, yes, this is the abnormality, this is the cardiac abnormality this fetus has. And to the extent now we have reached a stage of fetal therapy. There are certain therapeutic procedures which are being done intrauterine. So, things have moved on. But the unfortunate part is that, majority of us are still hanging around in this stage where whether the heart appears normal or abnormal, or maybe there is a percentage which is closer to a precise diagnosis. But then we all want, all those who are in whichever stage need to jump to the next stage, and that is the way we have to move forward. Because despite the accuracy of fetal echo, the second trimester detection of CHD is very low in the population at present. It is not just India. Even world over, the diagnosis of CHD in the second trimester is less, whereas the potential is huge, because there is a huge potential. So I was speaking to some faculties from abroad, and then they said, yes, the situation is the same everywhere. The prenatal detection is very low. Then what is the answer to that? We need to find a solution. And one important point is that we need to give attention to anatomic details of the heart in every examination that is done. See, there is nothing called level 1, level 2. Yes, fetal echocardiography as such is a specialized thing, but anybody who is doing a second trimester scan, it is mandatory on their part to see to it that they are looking at the anatomic details of the fetal heart. Because the moment you are doing a second trimester scan, you are doing it to rule out abnormalities. And you are you are indirectly telling the patient that, yes, I am trained and qualified to look for abnormalities. And if that is the case, you just can't say that, okay, I do brain well, I do spine well, but heart, I have a little, but heart is an equally important, part. And so if you can look at the brain well, you can also look at the heart well. Then you have to remove the phobia of the fetal heart. Now, that is the most important message that I want to give everyone who are young and who are who feel they are novices in fetal ultrasound. That because I realize that most of them have this feeling that when it comes to fetal heart, they say, oh no, I don't feel I'm very confident about it. There is some kind of a phobia. That is what is to be removed. And the only messages that you need to follow protocols. So the only answer to picking up cardiac anomalies is to follow protocols. See, good outcome comes from good diagnosis, and good diagnosis comes from good imaging. So as this is very, very true with fetal heart. If you're not doing good imaging, if you're not getting the planes correctly, you will never be able to make a good diagnosis. Because again, heart is you're seeing a heart in motion. It is not a static structure. And that is the reason you need to do good imaging. And good imaging again comes from image optimization and good presets. And that is one other message I would like to give, that get your card. You can't look at the heart in the same preset that you are doing your second trimester or third trimester scan. You need to have a specific preset for cardiac evaluation. I'm not getting into that, how to do, get what are the right presets, but then you all need to get into that. So, what the talk today is about new age possibilities and new age expectations. Now, let us see what are the new age expectations. What has changed as far as expectations is concerned. Expectations from the treating obstetricians, expectations from the patient. The biggest expectation now is a precise diagnosis. Everybody wants a precise diagnosis. Then they want us to give additional information which can be used for prognostication and counseling the patient. Nowadays, the moment you say there is a congenital heart disease, the patient is sent to a pediatric cardiologist for counseling. How is that person going to counsel unless you don't provide him information? You just cannot write something and say the heart is not normal or something, and this patient goes to a pediatric cardiologist for counseling. So that is another expectation. And the third most, something which people expect now is that they want us to give a diagnosis as early as possible. Like the pyramid is shifted, they say, and that is why the expectation is to get it done in, as far as possible, at least gross major abnormalities in the first trimester itself, or, early as possible. The people expect us to give us some kind of a diagnosis there. Now, why are these expectations, why more expectations have come up? Because the most important thing is that the postnatal management of a lot of these congenital heart diseases has improved. Those days are gone where you say CHD and the baby should go, the lady should go for termination of the fetus. Because now, if you look at the surgical outcomes of conditions like TGA, even tetralogy of Fallot's classical, they're excellent. As far as TGA is concerned, they say they have about 98% success as far as postnatal surgery is concerned. So, but all that is going to happen, the outcomes happen but then for that they need information, and that information is going to come first from the precise diagnosis and all that extra information that we can provide. Then there are specific conditions have specific genetic associations. Hence, it's important that we have a precise diagnosis so that we know whether this particular thing has an association with certain genetic abnormality. We know that there are some cardiac anomalies which can be associated with trisomy 21, but there are some which would be associated with 22q11 microdeletion. And suppose there is a patient with an extra cardiac abnormality, even an addition of a single finding in the heart can change the, it will change the counseling, it will change further testing. Hence, even, whenever there is an extra cardiac abnormality, looking at the heart in detail and trying to come to a precise diagnosis becomes important. and the new era possibilities, the new age possibilities. First of all, guidelines are available. See, we have plenty of guidelines from AIUM, from ISUOG, our own Society of Fetal Medicine, fetal heart guidelines are there. There are adequate training facilities. We never, those days when we started doing, there were no training facilities at all. The amount of webinars that we have now, the amount of, you have all those simulators on which you can learn doing fetal cardiac evaluation. Then the machines, the quality of machines, high resolution machines have come up with greater color pickup, and all this radiant flow and all these gimmicks that have come in. I mean, they're not gimmicks, but all those fancy things. I would say that you have the CRI and you have tissue, you have harmonics, everything adds up and gives you a better image, and that is why you are able to make a better diagnosis. The only thing that you need to change is your attitude. And then you have the stick echocardiography, you have the 3D of the fetal heart that you can do. I'll just quickly take you through. So you have to take use of all these possibilities that are there and go about fulfilling the expectations. The expectations eventually have to be fulfilled. Now, guidelines, you have guidelines for basic screening, extended basic screening, and fetal echocardiography. Now, I think we should forget basic screening, because what used to be basic screening was just looking at the 4-chamber view. So that is gone. Then they added up the outflow tracks to that, but now the extended basic screening also constitutes a 3-vessel and 3-vessel tracheal view. And then we have fetal echocardiography. Now, you extended basic screening, that should be done as an evaluation of low risk fetus as a part of routine prenatal care. You're doing a second trimester scan, you are supposed to do an extended basic screening. You can't just look at the heartbeat, you just can't look at the 4-chamber view. And then for fetal echo, the indications are maternal factors, increased nuchal translucency, extracardiac anomalies, IVF pregnancy, and the most important indication is patients with suspected cardiac anomalies and those patients with certain risk factors. Now, patients with suspected cardiac anomalies, who's going to suspect the cardiac anomaly? You only are going to suspect the cardiac anomaly. So that is why again the role of the extended basic screening becomes important, because if you don't suspect, you are not going to go further, and that is the reason you need to your cardiac protocols as far as the extended basic screening should have the situs, the 4-chamber view, the LVOT, the RVOT, and the 3-vessel and the 3-vessel tracheal view. That is the bare minimum, or you can say this is what extended basic screening is, and you have 5 steps in that. And also, I'm a very strong believer that the use of color should be a part of basic screening. A lot of guidelines put color as a part of fetal echocardiography, but then because we have machines, we have presets, everything is so easy, you can, and in fact, you will feel more confident about doing it if you add color as a part of your basic screening. And then whenever there is a suspicion, you do fetal echo. Whenever there are indications, that includes, you have the extended basic screening, plus you add, additional views. You can add the spectral Doppler, M mode, biometry. Yes, another good thing that has come is the Z scores, the Z scores or the Z scores. These are the ones which give you a quantitative, you're just not relying on a subjective assessment that this appears narrow or this appears dilated. You have Z scores available, and then you have tissue Doppler and the 3D, 4D, the fetal stick that I was talking about. So you look at the kind of resolution that we get these days, look at the kind of color pickup that we are getting. I think in spite of all this, if we are not really going ahead, that means there is something wrong in the way we approach. So, because as far as the technology is concerned, technology is giving us so much. You have the stake, you can do the multiplanar, you have the TUI, and coincidentally, most of us now have good machines. I think if you look at the high-end machines, I think the maximum number must be in India, because even in small towns, when I ask people what machine are you using, most of them are using high-end machines. And then you can do all this. And with this kind of color pickup, with this kind of facilities available, you are able to pick up most of the things. And once you have, you can do rendering, you can do 3D rendering. This also really helps you in, evaluating the spatial relationship of the great arteries, how they are placed. especially in cases like DORV. Then you look beautifully, you can get the coronal plane of the valves. Again, very, very important when you want to differentiate between TGA and DORV and DTGA. So these are all things which are available. You just have to think and go about. Then you have the seal out, and there you can see beautiful. Look at this. This is an hypoplastic left heart syndrome seen on seal out. So as far as technology is concerned, as far as training is concerned, we have enough. Now, what needs to change is the mindset. And the most important thing that needs to change is that a finding is not a diagnosis. The problem is, any finding that we find, we give it as a diagnosis. Now, I find so many reports with heart is not looking normal, 4-chamber view is not normal, outflow tracks not well seen, there is overriding of aorta, that is the diagnosis. Outflow tracks are parallel to each other, again, that is given as a diagnosis. Or 2 vessels seen in the 3VT view, or 4 vessels seen in the 3VT view. Remember one thing, these are all findings. These are all findings. That's the starting point. Now you have to move ahead and you have to come to a diagnosis. Like I'll take you through 3 examples. Now, when we look at chamber asymmetry, whenever there is a left heart which is small, every time it is not hypoplastic left heart syndrome. Now, that is the mistake that we do. You see LV which is small, hypoplastic left heart syndrome. Now, hypoplastic left heart syndrome, yes, is one of the important differentials for that. But hypoplastic left heart syndrome is an entity of its own. You can have mitral atresia with VSD, coarctation of aorta, interrupted aortic arch. All these things can have a small LV, again, DORV, TAPVC, unbalanced VSD. So it is, if you just say that the LV appears small, it's nothing. It is nothing. Or just LV appears small and you call it as hypoplastic left heart syndrome. No. In hypoplastic left heart syndrome, you have a small hypokinetic LV. The apex of the heart is formed by the RV. There is absence or no filling of the LV at all. You will find that the mitral valve would be thick. You won't find any antegrade flow across the mitral valve. The left atrium is small. The flaps of foramen oval would be diverted or opening into the right atrium from left to right because there is nothing going forward. And then most important thing you will find is that there is no forward flow. So you have mitral atresia, you have aortic atresia, no forward flow. And when you go into the 3-vessel tracheal view, you will find that there is a retrograde flow. Retrograde flow you are seeing in the aortic arch. So the aortic arch is filling retrogradely. That is hypoplastic left heart syndrome. Now look at the similar kind of a scenario. You have an LV which is small. Again, biometry helps. We have the RV-LV ratio there. And when I look at the 3-vessel tracheal view, you can see here you are finding that the aorta and the aortic arch appears narrow. And then we have the Z scores here. Aortic isthmus Z score is around -4 for the period of gestational age. You put in color, good. I'm getting a good arch view, and I can make out the posterior shelf there. And when I do a good feet 3D examination, there you can see I can make out the coarctation beautifully here. So I'm not, with the small LV was just the starting point. Now take another case. Again, you have an LV which is small, but in the 3-vessel tracheal view, what you are seeing is, now this is not the 3-vessel view, this is the 3-vessel tracheal view. What I am seeing is that the trachea is kissing the pulmonary artery. The trachea is kissing the pulmonary artery. That's the SVC there. You have the aorta, but then I'm not seeing the V. I'm not seeing the classical V that is being formed. And then, you go further and you realize that, yes, the arch is not being formed. You have the first 2 branches. You're not seeing that. And the left subclavian artery is retrogradely filling from the ductus arteriosus. So I have my diagnosis of interrupted aortic arch. Similar way, parallel outflow tracks, very, very common finding, which is labeled as a diagnosis. But once I have a parallel outflow track, I need to go further. Whether I'm dealing with a transposition of great arteries, then what type? Is it a DTGA or a congenitally corrected TGA? Or is it a DORV? Now look at this. So these are parallel outflow tracks, but when I look at the 4-chamber view, first of all, I have tried to confirm that the morphological chambers are normal. There is a concordance. So I know that the right atrium is opening into the morphological right ventricle and left atrium is opening into the morphological left ventricle. Now in the 3-vessel tracheal view, I am seeing the classical eye sign where you have the right-sided convexity. You have a single great artery. And then when you know, go systematically, you realize that the vessel which is arising from the morphological LV is the pulmonary artery. It is branching, and the one which is arising from the right ventricle is the aorta. And of course, you can see the aortic arch, which is arising from the anterior aspect of the chest. So this is what I would call as the DTGA. But here, another case, you have parallel outflow tracks. But when you look at the 4-chamber view, this is the left side, this is the right side. So the left-sided valve is more apical, and I'm seeing the moderator band on that side. So what I am dealing with is an atrioventricular discordance. So the left atrium is opening into the right ventricle, and the right atrium is opening into the morphological left ventricle. And the vessel which is arising from the morphological left ventricle is the pulmonary artery, and the one which is arising from the morphological right ventricle is the aorta. So you have the left atrium opening into the right ventricle into the pulmonary artery, and the right atrium opening, the left atrium opening into the right ventricle, and the right ventricle opening into the aorta, and the right atrium opening into the left ventricle, and that opening into the pulmonary artery. So this is congenitally corrected TGA. And when it comes to DORV, again, you have both the vessels arising from the predominantly from the right ventricle. But again, just saying that both vessels are rising DORV is not sufficient. We need to work up further. We need to see the VSD. We need to locate the VSD. We need to see the relationship between the great arteries, whether the aorta is anterior and to the right. And then when you have the VSD also, you also need to look whether it's a subaortic VSD or a subpulmonic VSD. And then we need to I know it is sometimes difficult to differentiate between the different types, but a sincere attempt should be made. Especially when you are looking at a DORV, look at the outflow tract abnormalities in the form of either there is an aortic stenosis or a pulmonary stenosis, because that actually is going to change the prognosis. You have a malaligned VSD with overriding of aorta. Again, a very, very common finding. But, and the moment you see this, either you write it as an overriding of aorta or you call it as TOF. But every time you have a malaligned VSD with overriding of aorta, it is not tetralogy of Fallows. It's not just the classical tetralogy of Fallows. Here you can see the Y sign classical 4-chamber view looks normal. There is you have overriding of aorta, and you will notice that the pulmonary artery is arising from the right ventricle. It is arising from the right ventricle, but is narrow, and there is an antegrade flow. So you have RV, pulmonary artery arising from the RV with antegrade flow, but narrow, with an overriding of aorta and malaligned VSD. This is classical tetralogy of Fallows. Another case with overriding with malaligned VSD, and then in the 3-vessel tracheal view, you cannot make out the second great artery at all. You are not seeing the second great artery at all. And so there was no antegrade flow from the RV, but what you could see is the MAPCAS. You are seeing the major aortopulmonary collaterals which are supplying the lungs. So this is pulmonary atresia with VSD. So, it was previously known as the TOF with pulmonary atresia, but now it is better we call it as a PAVSD. And then there is another case where you can see that you have an overriding of aorta, malaligned VSD. And when you look you're trying to look at the pulmonary artery, you will find that the pulmonary valve is absolutely dysplastic. The main pulmonary artery is dilated. The right and the left pulmonary arteries are also dilated. And when you put in color, you are seeing the to and fro, what we call as the yin and the yang, or the to and fro flow. This is classical of an absent pulmonary valve syndrome. And this is another case where you can see that there is a single great artery which is overriding malaligned VSD with overriding, but you have the pulmonary arteries which are arising from this great artery, separately on both the sides. So this is common arterial trunk. So the starting point was overriding of aorta. So this is how you need to approach. This is what needs to change, that okay, there is a VSD with overriding of great artery. Now what I'm trying to go and look about is I look for the pulmonary artery. What is its origin? What is its size? How is the flow? Antegrade or retrograde? So if it is not, pulmonary artery is normal, then it could just be a plain malaligned VSD. If it is from the RV, narrow with antegrade flow, then it is tetralogy of Fallot's classical. If it is from the RV, very narrow, no antegrade flow, retrograde flow, or MAPCAS, then it is the PAVSD. If it is from the RV, but dilated, large, with to and fro, we are dealing with an absent pulmonary valve syndrome. And if it is arising from the great artery itself, then we are dealing with the CAT. Another expectation is as early as possible. So we're not getting into the depth of it, but yes, it is possible to pick up major cardiac anomalies in the first trimester, and it is definitely an advantage. You have more time for genetic diagnosis, and of course you have an option to confirm at 16 weeks, and if required, early termination of pregnancy can be offered. Just showing you one case. This is a right aortic arch with left ductus arteriosus seen in the second trimester, and this is seen at 11 weeks 4 days. Now what is the difference? It is, I can be equally confident what I was in the second trimester to give this kind of a diagnosis. Of course, AVSD and all other things are much more simpler. And then also one should know that there are certain anomalies which would evolve in the sense they have an evolving nature, or sometimes they don't become apparent in the second trimester. They may become apparent later, like small VSDs may not become apparent at that time. And then you have major vessel stenosis, aortic stenosis, pulmonary stenosis. You may not find much changes in the second trimester, or they could be so subtle that you don't pick them up at that time. Then coarctation can evolve over a period of time. An aortic stenosis can evolve into a hypoplastic left heart syndrome. And then all these conditions, rhabdomyoma, hypertrophic cardiomyopathy, aneurysms, premature ductal constrictions, all these things actually are late onset, and they are seen in the third trimester. So friends, the steps in detecting a CHD is, very important. You need to recognize normal as normal. That is the first thing you need to do. Then you start recognizing abnormal as abnormal and follow the protocols. Pattern recognition, you have to get used to this pattern recognition, what particular thing has a particular pattern, and then extend your scan. Just don't stop there. Go ahead, try to see the same thing in different planes, and then try to achieve a final diagnosis. Once you have a final diagnosis, then you think about what is the genetic testing that we need to do. We have a complete session on genetic testing coming up after in about half an hour's time. And then you can involve a pediatric cardiologist for counseling the patient. And because see, a lot of times these babies, fetuses get terminated because of a lack of information to the parents. If they are given a proper information on what is the kind of surgery, what kind of results can occur, there are quite a few of these parents who would actually like to continue the pregnancy for things which can be treated. Because there has been a national, what you call, a mindset, anything with the heart, anything with the brain, okay, get this fetus out. And that has to stop. So whenever in doubt, seek a second opinion, try to achieve a follow-up. A very, very important thing. The best way to learn is to follow up on your own cases. So the new age expectations are high. We need to fulfill them. Evaluation of heart should be a part of every scan done, whether you're doing it 11 to 14 weeks, 19 weeks, 24 weeks, 28 weeks, 34 weeks, or even 38, 39 weeks. When they come for a Doppler or a growth scan, we still look at the heart because we could still see something which could have evolved. Even if at the last stage you pick up a ductal dependent lesion, you're going to give a great chance to the baby by delivering in a tertiary center. And then it's all about protocol. Don't stop after one finding. That's the message. That is the first finding that you see is just the starting point. and you need to go further and come to a final diagnosis. Because a baby is usually born with a presumptive diagnosis. There are no symptoms. Thank you very much.
Thank you, Dr. Vimal. That was a real extensive lecture telling us about the possibilities. Yes, with improved resolution of machines, 3D, 4D color resolution, the possibilities have increased, clear guidelines have come. Thanks for telling us about our expectations. We as a doctor, what are our expectations and what are the patient's expectations? Certainly following protocols and guidelines, give a diagnosis rather than findings, try to evaluate and diagnose it as early as possible, offer them genetic diagnosis, offer them an opinion with a pediatric cardiologist. The messages were very clear, very explicit examples. Thank you for a wonderful lecture. Dr. Narasimha Reddy, would you want to really add anything to this? Thank you, Vimal. I really enjoyed your lecture.
Yeah, thank you very much, sir. In fact, you are happened to be the first batsman, but you have scored a century. At the outset, I thank Ashok Khurana sir and TL and Praveen, and I congratulate Chinmay Raka to start our chapter. So, excellent start, sir. Thank you. Thank you very much, sir.
Thank you.
Thank you very much, respected chairpersons and Vimal sir, as usual. So thank you really, because I still remember, forgive me for repeating this again and again, but I still remember your example on Dopplers, which I always feel that nobody could have made it easier than that. I will not share that example here. Let that be a secret for the next time we have the Doppler session, and sir will share it with all of us. He has the art of making things very simple, and we've called this webinar Fetal Heart State of the Art to make it sound very clever. But sir has really given us the new age expectations and the new age possibilities, because it is a fact now that these technologies are available and our patients are aware of them. So we have to, include more and more things into our protocol and make our presentations and our fetal echoes more informative. There is just one question for you, sir, that can you share the VSD with outlet tract abnormal? But I think we'll take that in the discussion when we do it at the end of the session. So with that, we move on to the next session, which is a case presentation session. And we'll have clinical case presentation by some of our young Turks. And that will be moderated by the seniors. And I request all the seniors here to please ask questions if they feel that is needed in the case. And I have the honor of inviting on stage Dr. Nitin Krishna Rao. He is our pediatric cardiologist from Star Hospital, Hyderabad. And he has done his DNB in pediatrics and then DM in pediatric cardiology, and is one of the most approachable and experienced pediatric cardiologists of Hyderabad. He's our go-to person whenever we have a problem. And thank you very much, sir, for being here with us. And the cases will be presented on outflow tract anomalies by Dr. Sahiti Reddy, who is a junior consultant at Resolution Fetal Medicine Center and also the Joint Secretary of SFM Telangana, and Dr. Pranahita Reddy, who is a fellow in fetal medicine from Resolution Fetal Medicine Center. So, Dr. Sahiti, please share your screen and start your presentation. Dr. Nitin Rao.
Yes, please. Thank you.
Please moderate.
Looking forward, yes.
So good evening, everyone. Today we would be taking you all through outflow tract anomalies, which we have seen at Resolution Fetal Medicine Center. Congenital heart disease is
Make it full screen. Sahiti, make it full screen.
most common severe congenital abnormality and a leading cause of infant morbidity and mortality. Considering a birth prevalence of congenital heart disease as 8 to 9 per thousand, the estimated number of children born with congenital heart disease in India is more than 2 lakh per year. Of these, about 1/5 are likely to have serious defects requiring an intervention in the first year of life. As you see the picture here, the congenital heart disease is approximately 60 times more prevalent than the childhood cancer. So the systemic evaluation of the heart can help us to diagnose the congenital heart disease. Initially, in 2006, the International Society of Ultrasound in Obstetrics and Gynecology has told us to do the basic four-chamber heart evaluation. Later on, they have changed the guidelines for performing the basic as well as extended basic cardiac scan, which included the outflow tracks. Later on, ISWOG in 2016 has released the practice guidelines such as sonographic screening examination of the fetal heart, where they have told that we have to do the basic four-chamber view, the LVOT and the RVOT view. In 2018, AIUM, in conjunction with other societies such as ACOG, SMFM, and ACR, updated 2013 guidelines, which included both the three-vessel view and the three-vessel trachea view. Finally, in December 2019, they have released the practice parameters for performance of fetal echocardiography. Now I hand over to Pranhita to tell us about the embryology before we move on to the cases.
So on the basic overview of the embryology of the fetal heart is formed from the mesoderm. It is formed from the cardiogenic area, which is present in the cranial part of the embryo, which forms two endocardial tubes. These two tubes migrate together to form a single primitive heart tube. This primitive heart tube is divided into 5 distinct regions, that is the truncus arteriosus, bulbus cordis, primitive ventricle, primitive atrium, and sinus venosus. The truncus arteriosus later on divides and forms the ascending aorta and the pulmonary trunk. The bulbus cordis forms the outflow tracts and the right ventricle, and the primitive ventricle forms the left ventricle, and the primitive atrium forms the right and the left atria, and the sinus venosus forms the coronary sinus and the venous system of the heart. This primitive tube later on folds within the pericardium and eventually forms an S-shaped structure, which later on develops the chambers and the major vessels of which resemble the adult heart. So more on the partition of the truncus arteriosus and the bulbus cordis. The truncus arteriosus is divided into 2 separate channels by the aortico-pulmonary septum into an aortic and a pulmonary channel. This forms a spiral course. The spiraling of the aortic and the pulmonary septum positions the aorta into the left ventricle and the pulmonary artery into the right ventricle. The bulbus cordis also is divided by a conal septum into the right and the left outflow tracts. The conal septum unites distally with the spiral septum to form the conotruncal septum. These are 3 cross sections of the truncus arteriosus. So at the origin, you can see that the spiral septum divides into an equal aorta and the pulmonary trunk. At the origin, you can see that the pulmonary trunk is anterior and the aorta is posterior. In the midsection, you can see that the aorta lies towards the right and the pulmonary trunk towards the left. And in the cranial part, the aorta is anterior, positioned anteriorly, and the pulmonary trunk posterior. So on the embryological basis for different outflow tract abnormalities, in a common arterial trunk, there is failure of this septum formation that divides the truncus arteriosus into the aorta and the pulmonary artery, leaving only one combined outflow tract. In a double outlet right ventricle, the aortopulmonary septum forms normally within the truncus arteriosus, but there is incorrect alignment of the aorta over the right ventricle, which leads to the final position in which both the great vessels arise from the right ventricle. In TOF, or tetralogy of Fallot, the basic pathology is the anterior displacement of the conotruncal septum. So as we discussed in the embryology, the spiral septum divides into the equal aorta and the pulmonary trunk, equal halves of aorta and pulmonary trunk. But when there is anterior displacement of the conotruncal septum, you can see that there is anterior displacement, so the size of the pulmonary trunk is reduced and the size of the aorta is increased. So this causes pulmonary stenosis. Because of the anterior displacement of the conotruncal septum, there is malalignment of the VST, and because of this and the increased size of the aorta, there is the overriding of the aorta. In transposition of great arteries, the aortopulmonary septum fails to follow the spiral pattern, and it allows the aorta and the pulmonary arteries to get attached into incorrect chambers. So this is our first case. We had Mrs. R, who was a gravida 2, para 1 with no living issue. She gives a history of a previous child who unfortunately died at 6 months of age due to a cardiac defect, which she describes as AVSD. She did not have any reports available then. In this pregnancy, the first trimester screening was not done. She was referred to us at 22 weeks of gestation in view of her previous history. So our scan findings, the 4-chamber view, we had found a VSD, which was about 3.1 mm. There was in the outflow tract, there was a malaligned VSD, overriding of the aorta and small pulmonary arteries. So we had counseled them about the need of postnatal multi-stage surgery, and we had explained them that the final outcome depends on any associated chromosomal aneuploidies in the fetus. The option of amniocentesis was given with QF-PCR and CMA, and she was also advised neonatal counseling by our pediatric cardiologist. Later on follow-up, we had learned that she had gone to terminate this pregnancy for her personal reasons. So on tetralogy of Fallot, it is the most common cyanotic heart disease. It was named after a French physician, Louis Arthur Fallot, in 1888. Its incidence is about 1 in 3,000 live births. So as the name suggests, tetralogy, it has 4 components: the malaligned VSD, overriding aorta, right outflow tract obstructions. These 3 are found prenatally. Right ventricular hypertrophy is usually a postnatal finding. So the types of TOF, the classic variant is associated with pulmonary stenosis. The variants in which the TOF is associated with pulmonary atresia and absent pulmonary valve syndrome usually have poorer prognosis than the classic variant. Once a TOF is detected, we should stress on serial ultrasound monitoring, because stenosis, which would have been absent at the time of diagnosis in 2nd trimester, may develop later on in pregnancy, or a narrow pulmonary outflow tract may progress later to form atresia in the later gestation. Thus, it's always important to demonstrate an antegrade flow through the pulmonary arteries late in the gestation to exclude the need of any prostaglandin requirement after birth. The indicators for an unfavorable outcome include any extracardiac abnormalities, any associated chromosomal anomalies, which accounts for up to 20%, which includes trisomy 21, 18, and microdeletion of 22q11. Any severe pulmonary artery stenosis, absent pulmonary valve syndrome, and when the pulmonary valve peak systolic velocity of more than 87.5 centimeters per second at 19 to 22 weeks usually indicates the need for early interventions postnatally. Antenatally, once a TOF is detected, detailed anomaly scan should be performed by an expert to detect any extracardiac abnormalities. Fetal karyotype and a CMA should be advised, and the delivery should always be planned at a tertiary center with multidisciplinary care. Postnatal surgery, the definitive surgery is performed at about 3 to 6 months of age. It includes the infundibulectomy, which involves the removal of the obstruction, the closure of the VSD with a patch, and if required, pulmonary valvotomy. The mortality rate is about 2.5%. In case of pulmonary outflow tract obstruction, early intervention is required to maintain adequate blood flow to the lungs by a palliative aortopulmonary shunt. This is by modified Balloch tossing operation, which involves interposition of cortex conduct in between the left subclavian and the left pulmonary artery. Prognosis depends on the karyotype, associated extracardiac malformations, and the cardiac anatomy. Prenatal counseling should always include that the pulmonary outflow tract obstructions may evolve anytime during pregnancy, and an isolated TOF usually have very good long-term survival of about 90%. In a classic TOF with pulmonary stenosis, the outcome is usually good, and it requires usually only one operation during postnatally. When other variants are present, such as pulmonary atresia and absent pulmonary valve syndrome, then the prognosis is usually less favorable than the classic variant and may require more than one intervention. So this is the second case. We had Mrs. X, who was a primary gravida. She had come to us at 22 weeks of gestation for a TIFA scan. Her first trimester screening showed low risk for any fetal aneuploidies. The scan findings at our center, the 4-chamber view was normal. There was atrioventricular concordance. In the outflow tracts, we could see that the branched outflow tract was arising from the morphologic left ventricle, and an unbranched outflow tract was arising from the morphologic right ventricle. And there was parallel track seen. Unfortunately, this video is not playing. It showed the parallel outflow tract. And also in the also in the longitudinal view, we could see that the aortic arch has a wider angle as it's arising from the anterior ventricle, and it gives the appearance of a hockey stick. So here we had explained the couple that an isolated TGA has a very good prognosis after postnatal surgery. We had explained them the need of cardiac follow-up and also advised fetal karyotype and CMA. The couple declined and went on to terminate that pregnancy. So on complete transposition of great arteries, there is atrioventricular concordance and ventriculo-arterial discordance. Here, the incidence is about 1 in 10,000 live births. It is a congenital heart disease in which the aortic artery emerges from the morphologic right ventricle, and while the pulmonary artery originates from the morphologic left ventricle. So it can be either an isolated TGA, or it could be associated with a VSD, pulmonary outflow tract obstruction, aortic arch abnormalities, and AV valve abnormalities. So also in the diagnosis, in the three vessel trachea view, you could see two vessels because of the anterior positioning of the aorta in relation to the pulmonary artery. Color flow Dopplers usually show the characteristic ventricular arterial connections, and it is also useful for detection of small VSDs and also detection of pulmonary and aortic outflow obstructions. So some of the indicators of poor outcome, whenever there is a significant right outflow tract obstruction, abnormalities in the origin or pattern of coronary arteries, and when there is a restrictive foramen ovale where an early intervention is required. Usually TGA is not associated with any extra cardiac defects or any chromosomal abnormalities. So in the antenatal period, serial follow-up scan should be done to recognize any restrictive foramen ovale because it requires immediate transfer and intervention. When the TGA is associated with a VSD or a non-restrictive foramen ovale, it usually has a better prognosis, and a transfer to a pediatric cardiology unit is enough in the first few hours to ensure that the saturations are maintained. When TGA is associated with an intact ventricular septum, it requires immediate intervention by atrioseptostomy by Rashkin's procedure to provide adequate oxygenation, and prostaglandins are required to avoid closure of the ductus arteriosus. So the definitive surgery which is done is the arterial switch operation. So it is basically done by the transection of the aorta and the pulmonary arteries above the semilunar valves, then excision of the coronary arteries from the aortic root with the cuff of the aortic wall, then connecting the ascending aorta with the pulmonary root and the coronary arteries to the repositioned aorta, and also connecting the pulmonary arteries to the aortic root. So when the TGA is associated with an intact interventricular septum, the timing of the operation should be done usually within the first few days of life. When TGA is associated with the VSD, usually it has a better prognosis, and the surgery can be delayed in the first few weeks of life. This arterial switch operation is the anatomical correction of TG. The next is the Senning mustard procedure. It is a palliative arterial switch done between 3 to 6 months of age. The aim is to redirect the caval blood into the left ventricle and the pulmonary venous blood into the right ventricle. So this is more of a physiological correction of TGA. Then the REV procedure, it is done whenever the pulmonary flow obstruction is moderate to severe. It is done at 12 months of age. It involves the resection of the infundibular septum, and a tunnel is created which connects the left ventricle to the aorta, and direct anastomosis of the right ventricle to the pulmonary arteries. The prognosis in an isolated case is very good. It's about 90%, and a prenatal diagnosis helps in 13% reduction of the surgical mortality. In cases when there is additional findings such as pulmonary stenosis, the outcome is usually less favorable. So the next case will be taken by Dr. Sai.
So we had Mrs. J. Primey, 29 years old, who came with the report saying omphalocele. there was no significant past or personal history or family history. She had a dating scan followed by an NT scan, but there was no attached screening. At T5 23 weeks showed abdominal wall defect, which they were suspecting it to be omphalocele. The abdominal wall defect was identified due to the weakness of the abdominal wall, and protrusion of the contents has been ruled out, thus ruling out it to be omphalocele. On evaluating the fetal heart, on the 4-chamber view, we could see a ventricular septal defect, and going to the outflow tracts, it showed the outflow tracts which were arising both from the right ventricle. At the origin, we could see the parallel outflow tracts, and the color Doppler shows the similar image. So we have concluded it to be a double outlet right ventricle. So these are the autopsy findings of the same fetus, where we can see the parallel outflow tracts which are arising from the anterior right ventricle. So the double outlet right ventricle is double ventriculo-arterial connection from the right ventricle with a ventricular septal defect and with a variable spatial relationship of great arteries. The incidence is between 3 to 6% in fetuses and 2% in postnatal life. The significance is there is no crossover of the outflow tracts, and they seem to be parallel in spatial arrangement. Coming to the anatomy, both the great vessels arise more than 50% from the same ventricle, that is the right ventricle. VSDs can be either a subpulmonic VSD, subaortic VSD, or a doubly committed VSD or non-communicated VSD. The outflow tracts may be obstructed due to stenosis or atresia or aortic coarctation. There are usually 16 types of DORV, but the majority of them being the phallic type, where you see a subaortic VSD and normal relationship of the great vessels with a pulmonary artery obstruction. In Taussig blink type, you see a subpulmonary VSD and there is malposition of the great vessels. There is another type where you see a subaortic VSD, but there is no pulmonary stenosis. The spatial relationship helps in identifying the surgical procedure required and the prognosis. The abnormality requires a monitoring, as the pulmonary outflow obstruction may worsen and there may be ventricular hypoplasia as the gestation progresses. So the close differential diagnosis of DORV will be TGA or TOF because of anatomic relationships. There is a high risk associated with fetal aneuploidies, that is 12 to 45% with trisomy 13 and 18, and to a lesser risk of 22q11 microdeletion and trisomy 21. Once it is detected, checking for fetal chromosomes is mandatory. Rule out other cardiac and extracardiac lesions. A post-scan counseling, which includes to explain the changing nature of DORV, is a must. Delivery should be planned at a tertiary care center. The postnatal therapy, that is the surgical management, depends mostly on the type of ventricular septal defect. In subaortic VSD, and when there is no outflow tract obstruction, it is not a duct-dependent lesions. The early closure of VSD with a patch is done only when the symptoms are seen and the neonate fails to thrive or develops unresponsive cardiac failure. In the type where there is a subaortic VSD with an obstruction to the outflow tract, removal of obstruction plus VSD patch and pulmonary valvulotomy should be done. In subpulmonary VSD, arterial switch operation is done. When there is a subpulmonary VSD with an outflow tract obstruction, REV procedure modified by Rastelli is done. So in utero detection of congenital heart disease has many important implications. It provides prenatal counseling and diagnostic testing for aneuploidy that can provide valuable information for discussion of pregnancy options. Plan for delivery at an appropriate facility that can provide the highest level of neonatal care can be done. Prenatal detection of congenital heart disease has been shown to improve the neonatal surgical outcomes and childhood developmental milestones and reduce neonatal mortality. Fetal echocardiography in experienced hands can detect up to 90% of serious congenital heart disease in a low-risk population. The 4-chamber view alone can detect up to more than 50% of cardiac abnormalities. 20% of the abnormalities will be outflow tract or conotruncal anomalies, but only 30% of them can be detected in the 4-chamber view. Rest of the 70% needs to evaluate the outflow tracts as well as 3-vessel and 3-vessel trachea view. So the detection of outflow tract anomalies is particularly important as many of these lesions are duct dependent. That is, they require maintenance of patency of the ductus arteriosus, which normally closes after birth and thus warrant a high level care, neonatal care after delivery. Without a prompt intervention, including a surgical repair, many of these outflow tract lesions can result in death or significant morbidity. So once we detect the abnormality, we have to balance the risk of continuing the pregnancy, the benefits associated with postnatal surgeries, along with the cost. So the simple technique which allows us to get to the diagnosis is the sweep technique. Only a subtle angulation or sliding of ultrasound probe helps us move through different places. The 4-chamber view is the starting point. We see the normality of 2 vessels, the connection of appropriate ventricles, the relative size of the great vessels and position, and adequate opening of the arterial valves. The great vessels are approximately equal in size and cross each other at right angles from their origin as they exit from their respective ventricles. This is the normal crossover. So here, as you see, when we go through the LVOT, from the 4-chamber view, if you move the transducer to the right fetal shoulder, you will see the LVOT. From the LVOT, if you angulate it towards the fetal left shoulder, you will see the RVOT. Again, go back to the 4-chamber. If you move cephalate by maintaining the transverse plane, you will see the 3-vessel view. In the 3-vessel view, the pulmonary artery is the anterior most, followed by the aorta and the superior vena cava. So in the 3-vessel trachea view, if you move little more upwards, you see the V-shaped appearance of ductal and aortic arches converging at the descending aorta. So this table helps us in differentiating the outflow tract abnormalities. If you see the table, most of the outflow tract abnormalities, except for the congenitally corrected TGA, the 4-chamber view remains unremarkable. In TOF, on the LVOT view, you see a mal-aligned VSD and an overwriting of aorta. On the RVOT, there is a small pulmonary artery, and the aneuploidies such as 22q microdeletions, trisomy 21 and 18 are related to TOF. On double outlet right ventricle, you see the outflow tract where more than 50% of the left ventricular outflow tract arises from the right ventricle. The right ventricular outflow tract appears to be normal and there is no crossover, and thus parallel outflow tracts are seen. This is associated mostly with trisomy 13 and 18 and to a less extent with trisomy 21. In DTGA, the outflow tract, that is the left ventricular outflow tracts, arises from the anterior most ventricle, that is the right ventricle, and there can be a malaligned VSD. The right ventricular outflow tract arises from the posterior left ventricle. There is no risk of aneuploidy with DTGA. When you see the congenitally corrected TGA, there is atrioventricular discordance. Along with that, the left-sided tricuspid valve is attached to the ventricular apex. Here, the outflow tracts arise from the opposite ventricles, that is LVOT arising from the right ventricle and RVOT arising from the left ventricle. Virtually, the aneuploidy association is absent. In common arterial trunk, you see only one truncal valve, which is commonly connecting both ventricles. So coming to the take-home message, basic evaluation of the fetal heart in mid-trimester with 4-chamber LVOT, RVOT views can detect maximum number of outflow tract anomalies. Post-scan counseling by fetal medicine specialists, pediatric cardiologist, and a neonatologist helps the parents understand the nature of the defect and postnatal implications. Chromosomal aneuploidy association is high, so it warrants testing once the couple decides to continue the pregnancy. As the lesions are progressive in nature, close monitoring till delivery is required. All the heart defects may not have cure, but we can care for the fetus by diagnosing at the correct time by standard evaluation. Thank you.
Yeah, very nice. Very nice case, very well presented.
Thank you, sir.
And both of you cited extremely good cases, but if the video had worked, it would have been better. But in continuation of Bimal sir's excellent talk that was there, I just have to say one thing, that both of the first 2 cases, they both terminated the pregnancy. Like Bimal sir said, you have very good, excellent postnatal outcomes, and we should actually encourage them to continue pregnancy, because outcomes are extremely good if diagnosed on time and operated on time.
Yes.
The one thing I want to say is that TGA, that what you said is correct. But basically, when you got to TGA, the plan is to do arterial switch surgery, switch the aorta and pulmonary to the right, proper side. So, and we usually do it at about 5-6 days of age. And if there's a VSD, we do it at 2 weeks of age. And we avoid prostate as much as possible, because prostate you can have apneic episodes. Longer prostate, you have bleeding issues, you have bone issues. So we try to avoid as much as possible. And the balloon atrial septostomy that you did was very common earlier, but we avoid as much as possible, because it becomes a second procedure. There's a potential for infection. And there's a study which showed that children who had a BS, balloon atrial septostomy, tend to have sometimes seizures and neurodeficits are common. So we try to avoid that as much as possible. And if you, like you said, if you diagnose at the right time, the outcome is extremely good. Yeah, and the long-term result also extremely good. We had a case we operated 2 years back for TGA. It came back with some supravalvular aortic obstruction. So when I underwent a second surgery last week, but most of them are doing very well. And Dr. Pranit, the thing of tetralogy of Fallot, the more than the absent pulmonary wall, the pulmonary atresia is a bad risk factor.
Yes.
Because absent pulmonary wall, you've got a good wall, you've got a good arteries, but they're aneurysmal arteries. So these don't go into spells. They don't require beta blocker, but they require correction at some point of time. You may require replacement of condyle later. But the worst prognosis is a pulmonary atresia where you don't have a good sized pulmonary arteries, native pulmonary not there, you have collaterals, that makes it very messy. So counseling on time, counseling by a proper specialist in time, and we encourage them to go ahead with pregnancy. They have a very good outcome. Something like hypoglossal left heart, that's very bad, but most of them have excellent outcomes.
Thank you, Dr. Nitin. And stop sharing your screen, Saiti. There are some questions that have come there. How to differentiate between a pulmonary atresia and severe pulmonary stenosis? Dr. Nitin, would you?
Yeah, it all depends on seeing the antegrade flow. And like pulmonary stenosis can actually progress to atresia later on. So if you see of something like that second case that she showed, narrow pulmonary artery, you have to follow them up. It may become worse, it may become severe. You always look at the antegrade flow. And usually if you have a good antegrade flow, you'll be able to see a good size, fairly good size main pulmonary artery and branches also. When you got atretic pulmonary wall, you may not have antegrade flow, the main pulmonary will be very small. So like Bimal sir said, look at the Z-scores if you can, if it's possible. And the main thing is look at the antegrade flow. Sometimes we have a very faint antegrade flow, so those are high risk for going to pulmonary atresia. And the good thing is you have pulmonary atresia, which in the end of third trimester, sometimes 30 to 36 weeks, they have a very good prognosis where they have a good size confluence. So it all depends on antegrade flow. Now, suppose you detect something like a abnormal PDA coming from the arch of aorta, then that gives an idea it's probably atresia, not stenosis.
And the flow across the foramen ovale also, should we keep it as a protocol every time while doing our regular ecos, or should we do it only in cases of anomalies?
No, we should. Like it's then one of tick boxes to be checked. A protocol we follow, it's always good.
So what do you suggest? Just the opening of the foramen ovale into the left atrium, that much is enough, or do we need to take some objective parameter?
Opening foramen ovale, the size of the foramen, the flow, how it is. Very rarely you may have a turbulent flow, you may have a restrict foramen ovale. So those things would matter, and the size of this matters. Yeah.
So Dr. Chelapan has commented that it is better to give a non-directed counseling instead of encouraging them to continue. That's something which we have to, like this particular case which was shown, that was quite a favorable case in terms of our clinical judgment, but they actually decided to discontinue. So the counseling is always non-directive. The final call is the patient's. If it's a retrograde flow, yeah.
Yeah, I agree that the counseling should be non-directive, but then the information needs to be provided. See, if I try to do everything from my end and try to counsel and just say a few words, if the counseling is done by the right person, if the counseling is done by a pediatric cardiologist who explains to them And to the extent that in India, the cost is also a very important factor. To the extent where this surgery can be performed, what would be the cost? Then definitely some of them, I'm not saying, this is going to happen overnight, but some of these babies definitely can be, they can be citizens of India tomorrow. They're just getting terminated.
Right. And when we have a certain in our place, we feel we actually call the surgeon, the cardiac surgeon, we speak to them together. So they have a fair idea of what they have. And I'd just like to tell you the way you counsel, like there's a Dr. Chinmay's patient who's about 4 or 5 years of age now. The child was very precious pregnancy. Parents were very keen, not affording, but they wanted to continue. He diagnosed as a pulmonary atresia, maybe at 24, 25 weeks. The child got delivered. He underwent a PDS 10 at 10 days of age. They affordability was zero, but still they wanted to go ahead. We got government funding. And then underwent another surgery called Glenn surgery at 9 months of age. And last week underwent surgery called Fontaine surgery. The family is very keen. They're very keen. It depends how you counsel them also. And of course, they would it has to be non-directive, leave the option to them. But this family is very keen on continuing, so they've had a good outcome. And one thing like Dr. Pranita said about tetralogies with chromosomal anomalies, yes, you should always look for Daijo syndrome. In fact, one of our fellows has completed a thesis on, we sent all our patients with tetralogy to Dr. Shagun for a genetic counseling. And quite a few Daijos were picked up. So we have to do a genetic counseling.
Yeah, if I may add to that, no, like
Yes,
when we are counseling the patients, it would be also important to include the genetic testing in that counseling. I mean, because that would really make a big difference in the prognostication. Besides the type of cardiac defect, the other aspect which is really important, which we hope we'll cover in our session, is that we need to find out whether the baby has a genetic abnormality, because that really changes the counseling and the prognosis.
right.
So that should also be integrated in the counseling situations, actually.
And we also counsel about the risks of, especially because we get a lot of consanguinity here. So risk of future pregnancy is also there.
Yes,
something we highlight.
Will accept all these genetic testing and everything only when there is a desire to continue.
Exactly.
Yes,
So the primary thing becomes is that whether they want to really take that chance of surgery. Once they are ready for that, then they will do all the testing,
Right,
yes.
But if their termination is the answer, is already there in their mind, then they would, most of them are not prepared to do genetic testing.
No, but then I think.
So the other, sorry.
But I think once we have to counsel them, I think it should be a complete counseling, in the sense genetics also should be told to them that these are the things that have to be done. I mean, whether they do it or they don't do it is their problem. But then basically when we give a counseling, I mean, when you do the counseling, genetics has to be included, because now we know that the genetics has a role to play in evaluating congenital heart diseases. And hitherto we used to think that most of the congenital heart diseases, the cause was not known, but now we know that there is a genomics and genetics paving way for identifying these genetic problems. So it is essential that we need to explain them the recurrence rates. So it is essential to outcome of these patients. And while not only the surgical procedures, not only the outcomes or the cost of the surgery, it's also essential that the family should know about the genetic configuration, a genetic background. Well, the decision not to continue or continue is the patient's ultimately. We cannot prime them. But I think we should definitely include the genetics even before whether they take. I mean, maybe we can help them to take a decision regarding the termination based on the genetics also.
Thank you, sir, because that really sets the scene for the next topic that we are going to discuss here. Because as you said, that counseling has to be holistic, and that's what we actually do when we start with one anomaly. Like Dr. Bimal said, look for all other anomalies, rule out structural associations, and then go on and establish the kind of cardiac anomaly and move on to the genetics. So there are many interesting questions coming up, and I'm sure this topic will demand a lot more discussion. So we'll move on to the next case presentation and do all the question answers thereafter. Dr. Khurana has the audience interaction session. So for the next session, Praveen sir will be helping us moderate that along with Dr. Shagun. Dr. Shagun Agarwal is an additional professor in Nizam Institute of Medical Sciences in medical genetics and has earned a very important DM degree in medical genetics. Very few people in this country are properly trained in medical genetics. And therefore, we are lucky to have her here in Hyderabad because their team is again our to-go team for all genetic problems. She has many publications in peer-reviewed and indexed journals, and she will be moderating this discussion, which will be presented on a case presented by Dr. Priya Ranganath, who has completed her DNB in medical genetics from Nizam Institute of Medical Sciences. So over to you, Praveen sir and Dr. Shagun.
Thank you, Dr. Chinmay. So again, at the outset, I would like to thank all the mentors of SFM for blessing our first monthly meeting. And Praveen sir, I would like you to please introduce this session, and then we can move on to the proper cases.
Thank you, Chinmay, and thank you, Shagun, for giving me this opportunity to be with you all. And today's topic being the genetic perspective of the fetal cardiac diseases. Few years back, I think we were all the time thinking about whenever we diagnose a congenital heart disease, we used to think the cause is not known. But with the genetics and genomics coming into play, we now can attribute to a very major chunk to the genetic causes which are responsible for this sort of a abnormal congenital heart diseases. Basically, identifying this biological pathway leads to a better understanding of cardiac development. Not only that, it is essential that it has a greater impact on the management, understanding, and the physiology as well as the anatomy of these congenital heart diseases based on the genetics. The reason is that once you identify a genomic cause for the congenital heart disease, there are certain aspects that we are very sure about. Is that we know that we can talk about the outcomes. We know we can talk about the what do you call as the provide information regarding recurrences, and at the same time, it is essential that we need to understand the which test to use where. I think that is one of the most important things that I would like Shagun and her colleague to cover up, because this is going to be the take-home message for all of us. Because unless we know which test to do at what time, and it becomes very difficult for us as practitioners of fetal medicine to handle this congenital heart disease. And as we all know, the incidence of congenital heart disease is pretty high. So it is essential that we need to understand this particular perspective. And I feel one of the expectations and the developments that are taking place as far as the fetal heart is concerned is genetics. I think genetics has a role to, one of the most important aspect that we have to think in terms of. Thank you, and Shagun, please take over. And
yeah, thank you, sir. Thank you for that wonderful introduction to this whole session. So at the outset, I'll just like to again reiterate, Priya, you can move the slide, that of course congenital heart diseases are one of the commonest malformations which we see during antenatal ultrasound. Please move the slide, Priya, Dr. Priya. And whenever we see, okay. So whenever we see a structural abnormality of the fetal heart, so we've already gone through the wonderful lecture and then the illustrative cases on how actually the exact anatomical delineation helps in prognosticating, taking decisions regarding the pregnancy, discussing regarding the postnatal management. But on the other hand, what is the other important aspect which is equally important when we want to prognosticate the family is to realize whether there is an underlying genetic cause of this cardiac defect which we are seeing. So a cardiac defect, or for that matter, any malformation, could be an isolated malformation, and often such isolated malformations would be easily repairable postnatally in most of the times, except for, of course, some of the lethal ones. But then these malformations could be part of a genetic syndrome, and that is the baby which we really want to diagnose, because this baby would later on have other issues besides the cardiac issue. So the cardiac issue can be corrected very often, but the other coexistent issues of a genetic syndrome would be something which may not be amenable to therapy. So that's why that's where the role of genetics comes in. So let's go to the next slide. So there are, of course, various etiologies of a congenital heart disease, but then we are going to focus on the genetic condition. Next slide. So if we want to, I mean, I don't want all of you to read the whole slide. I mean, it may look a bit confusing. So all you need to just remember is that genetic disorders could be of three main types. We could have the gross chromosomal abnormalities, which you will see on a karyotype. So like Down syndrome, trisomy 13, 18, all these would be easily visible on the karyotype. And for all these years, the karyotype was the single test which was actually available in the prenatal period. So, but then of course, just as ultrasound technology has evolved, the genetic technology has also really evolved along the same line. So what we can now see is much more. So we can now look at even smaller parts of the chromosomes which are not seen in a karyotype, and this can be done using some other techniques. And one of the commonest one you would have probably heard of, and we had seen in the previous cases, is chromosomal microarray. So a chromosomal microarray can check for small abnormalities in the chromosomes, which are microdeletion, microduplication syndromes, the prime example being Digeorge syndrome, which is a deletion of 22q11.2 region. And then the third category of genetic disease is the single gene disorder, where you have a defect at the level of the DNA. And this will not be seen on a karyotype, will not be seen on a microarray, and you will have to sequence the DNA to find this kind of defect. Next slide. So when we have a congenital heart defect, all these three kind of genetic diseases are very much possible. So you could have Down syndrome or other gross chromosomal abnormality in 30 to 40% of prenatally detected congenital heart diseases. Or you could have 22q11.2 deletion, that is Digeorge syndrome, in 5 to 20% of such cases. Or you could have a single gene disorder, the commonest one of which being Noonan syndrome, in 2 to 15% cases, where you have an increased NT with or without a congenital heart disease. So when you have a congenital heart disease, the baby could be having an isolated cardiac disease, or the baby could be having any one of these three categories of genetic diseases. And these other problems of, or the other features of these diseases may not be visible on scan, but these children would postnatally go on to have intellectual disability, other systemic problems for which there will be no cure. So when we see next slide, so when you're seeing a congenital heart defect on scan, so of course, with all your great imaging skills and all the wonderful sessions we are having, you would of course be able to anatomically define the lesion, to ascertain what is the likely postnatal prognosis, what are the interventions available postnatally, prenatally. All these facts are of course very, very important in the counseling. But the other important part, which is often missing and sometimes neglected, is the fact that this defect would be part of a genetic disease, and then this child could have other problems in the postnatal period. Unless we do a genetic test, you would not be able to distinguish the baby with a genetic syndrome and the baby with an isolated cardiac disorder. So this part is also equally important to include in the workup, to include in the counseling, and on the basis of this, then subsequent management decisions can be taken. So now I'd ask Dr. Priya to show us some cases whereby we can see what kind of genetic test we should be doing in what kind of scenarios, and how it really helps these families. Dr. Priya, please.
Good evening, everybody. So this is the first case. This is a non-consanguineously married couple with a previously healthy child, and they came to us in their second pregnancy with an antenatal ultrasound showing DORV, double outlet right ventricle, and the child also had polyhydramnios. Now, no prenatal procedure was done, and they had terminated the pregnancy at around 26 weeks. And the fetus was terminated and brought to us for autopsy. Now, fetus was bought in formalin, and they had also preserved some cord blood that helped us to make the further genetic testing. So if you see here, this is a fetus, and the fetus had very subtle dysmorphic features. So it just had a mild retrognathia, some low set ears, and some overlapping of fingers, which you can see in the photographs. When we went ahead and did the internal examination, the weight, height, and all were in the lower centile, around 5th centile. And internal examination showed this kind of a distended bladder, which is the distended bladder, and also this was very tense distended bladder, and there was a left hydroureter and the right hydroureter, which was slightly more prominent. And then the urethral opening also of the bladder was normal, but the urethra could not be traced till the could be traced only till the proximal half, and no definite anomaly could be visualized when we traced up to the proximal half of the urethra. Now the kidneys appeared normal with mild dilatation of left renal pelvis. What was very important was this significant finding. There was a presence of there was a presence of large gut malrotation with descending colon crossing over to the right side and sigmoid being present on the left side, which you can see in the photographs. Then when we went ahead and did the cardiac examination, we could see that all 4 cardiac chambers were, however, normal size, normal in thickness, and normal atriovenous connections were also present, and there were no septal defect. Now, the aorta originated from the right ventricle. And the main pulmonary artery from the left ventricle, indicating that there was a transposition of great vessels. And there was some preductal quasitation of aorta, which you can see in the second picture there. Quasitation of aorta and the ductus arteriosus, branches of pulmonary artery, and the descending aorta all were unremarkable. So from the cardiac examination, we could infer that there was a transposition of great vessel and there was a preductal quasitation of aorta. So since we had some sample preserved, luckily for this case, which is generally not true in all the cases, we were able to do karyotyping for this picture and for this fetus. And very clearly, the karyotyping showed a trisomy 18, and the diagnosis was made. And then we went ahead and counseled the couple regarding the same. So among the counseling points, we had an antenatally apparent isolated cardiac defect, that is DORB. The additional findings which we were able to pick up on the autopsy were the dysmorphism, gut malrotation, urethral stenosis, and athlesia. And there was a complex cardiac defect. So this added to our phenotype so that we could further get a clarity on what kind of test to perform. So we did a karyotype because we had a blood, because we had a suspicion of an aneuploidy, trisomy 18 here, and the karyotype confirmed the diagnosis. Now, because this was a free trisomy, we were able to give them a recurrence risk also in the counseling, which is up to 1%, and then prenatal diagnosis by amniocentesis and fetal karyotyping in subsequent pregnancies with a recurrence risk of about 1% was told to the patient as a counseling advice.
So then, Dr. Priya, I think this was a very simple case. So maybe you could just tell us these few things. So one being that how common are chromosomal abnormalities in prenatally detected congenital heart diseases? Then are there any specific CHDs where we should, I mean, if we see, we can think of a particular chromosomal abnormality. Is there any correlation like that? And like, in this case, like we got trisomy 18. So do you think if we could have just, a patient who comes later in pregnancies, because often some cardiac defects are diagnosed a little later, so then we would need to do a rapid diagnosis. So can we just do FISH, or should we also do karyotyping, because that adds to the cost for the patient? So can you just answer some of these very basic things?
Yes, ma'am. So for the first 2 questions, how common is the chromosomal disorder? So chromosomal disorders are found in around 30 to 40% of fetuses with cardiac defect. Answering the question where there is a specific disorder for a specific syndrome that we should consider, all of us know these basics, that Down syndrome or trisomy 21, we should think, we should suspect if there is an ABSD, and Edwards or trisomy 18, we should suspect when there's a septal or DORB. And Fetal syndrome or trisomy 13, we should consider when there's a septal abnormality. And Turner syndrome, when we see a coarctation of aorta, bicuspid aortic valve, or mitral valve prolapse. Now, other unbalanced chromosomal abnormalities can also be there. So trisomy 22p, we should suspect a PAPVD or multiple abnormalities when they're present. Now, answering the question whether FISH can only be done, or can we do just for a rapid diagnosis for FISH, or we should go ahead and do the karyotype. Always a karyotype is very essential, despite whether you do the FISH or you don't do the FISH, because karyotype gives us additional information by in 2-3 points that they can also pick up other aneuploidies other than the 13, 18, 21 and X and Y chromosomes, which we are generally looking with the FISH probes. Apart from that, it can also pick up some large deletions. It can pick up something called as a marker chromosome also. And something else like whenever there is a translocation, not a free trisomy, but a translocation trisomy, that can also be picked up. And picking up this translocation abnormalities can again then in turn help us to again check it in their parents whenever we see this translocation and see whether this is coming from the parents, and that would again in turn alter the recurrence risk for the couple in the future pregnancy. So it helps us in prognostication. So karyotype is essential, though FISH can be done for a rapid endocarditis. So here,
yes.
Yeah, here is just a special scenario that Madam had kept, that whenever you have this translocation 21-21, we think of a recurrence risk of almost 100%. So that tells you how differently the recurrence risk changes. And I also forgot to tell a couple of points that whenever we have a free trisomy, we think the recurrence risk is about 1%. And whenever we have a balanced chromosomal rearrangement in a carrier, which is detected, we give a recurrence risk about 5 to 15%. If the father is the carrier, then the recurrence risk is around 5 to 7. And when the mother is a carrier, the recurrence risk is around 10 to 15. Shall I go ahead with the next case scenario now?
So the main message I think from this case is that please do a karyotype irrespective of whatever other methodology you're using for making a diagnosis, because that's really important for recurrence risk counseling. Yeah, I think we can move to the second case.
Yes, thank you. So in this case, you're seeing there is a non-consanguineously married couple with a history of first child who just presented with autism. It's very vague phenotype. So presented with autistic features. And in the second pregnancy, the child antenatal scan had detected a tetralogy of Fallot. So they had also done a further amniocentesis and they had done a karyotyping. Now this has come normal, and further they were referred to us. So when they were referred to us, we did the, because we saw TOF as one of the phenotype and we have done the autopsy and everything else, we had a suspicion of Digeorge syndrome. So we did an MLPA. So MLPA is a technique called multiplex ligation dependent probe amplification. So what we do in this technique is we have specific probes for some critical regions of that we have identified of certain microdeletion disorders. Now, when we put this probe, we get to know whether there is a deletion or duplication of these particular probes. And based on that, we have an interpretation of the results. So for Digeorge syndrome, MLPA is the best technique and we should always do it. So MLPA was done and we detected a deletion of probes in the 22q11 region. It's the Digeorge syndrome region. So further, we went ahead and did the MLPA in both the first child and also in the parents, both the parents. We saw that the first child also had the similar deletion and the mother also had the same deletion. So this again goes on to illustrate the fact that Digeorge syndrome has variable presentations from completely asymptomatic to something like autism, something like multiple malformations, cardiac defects, intellectual disability. A lot of phenotypes are there with Digeorge and can have a varying presentation also. So we should be very careful in this.
So I think the first question probably you've already answered. So when we detect prenatally, even if you diagnose Digeorge syndrome in a baby, actually predicting the postnatal phenotype is very tricky, because as we saw in this family itself, the mother was completely asymptomatic. And the previous child also had autism as a presenting feature. So there can be so much variability in the clinical presentation. So even after making a diagnosis, the counseling is still challenging. So, but then again, Dr. Priya, like in this case, we had made a diagnosis for the fetus. So do you routinely check the parents, and why do you do that?
So basically, again, for the same reason that this can have a very variable, Digeorge syndrome can have a very variable expressivity. So you can have parents who are completely asymptomatic. And when you detect the parents can have, can also carriers or do not also have this deletion, same deletion in the 22q11 probe, then you can say the recurrence risk is now around 50%. Of course, the postnatal phenotype again is variable, but the recurrence risk can be ascertained by knowing whether the parents are also having this deletion of Dajot syndrome regions. So that is the reason why.
And what kind of congenital heart diseases are more associated with 22q deletion?
So conotruncal defects are the ones which are commonly associated with the 22q deletion.
And then are there any other microdeletion, microduplications, and like should we be thinking of doing some other tests rather than doing a targeted testing for Dajot syndrome?
Yes. So there are many other microdeletion duplication syndromes. The one which we are commonly aware of is the Williams syndrome. So here they present with supravalvular aortic stenosis, fetal growth restriction, and some facial dysmorphism. And the other one is the Wolf-Hirschhorn syndrome, which is nothing but 4p deletion syndrome. They also have this very typical Greek helmet, Greek warrior helmet-like appearance. So that's the typical facial dysmorphism there. And then you have the Clyde-Chat syndrome, which is 5p deletion, which can have presence of DSDs, cryptorchidisms, facial dysmorphism, and so on. And there are many other microdeletion syndrome. And many of these are associated with other findings, especially intellectual disability, which is very common. And answering the second question, whether we can do any other test, yes, of course, we can do other tests. That is, a chromosomal microarray can be commonly done. So what happens with the MLPA probes are, these are designed for specific syndromes only. So whenever we are in doubt of the actual phenotype of this, and we are not able to match it exactly to a particular phenotype, then we are safe in ordering a chromosomal microarray, which is a genome-wide study of microdeletion and duplication. So it can genome-widely pick up any copy number variations, and that is why they help us in making that happen.
So I think you've already covered this. So then, I think there are one or two questions also in the chat box related to this. So MLP or FISH, any one of them can be done actually. So both of them are equivalent. There are some just differences at the level of the laboratory, but both are good enough to detect Dajot syndrome or to detect a specific microdeletion syndrome. But now that we have microarray available, which can look for so many other microdeletion, microduplication, and we don't know that what kind of microdeletion baby could be having. So with availability of technology now, this is the test of choice actually. And there are studies now, and there are a lot of already available data which is showing, next slide, that in case of a isolated cardiac defect, around 5% of these fetuses would have some kind of a microdeletion, microduplication, which will be seen only on microarray, not on karyotype. And if there are multiple anomalies, this figure can touch around 9 to 10%. So I think with this, so basically microarray is the test of choice. But if affordability is an issue, if the baby is having a conotruncal anomaly or there are other findings like thymic hypoplasia or something, and you're strongly suspecting Dajot, then you could still do a targeted test like MLP or FISH if there is an affordability issue. Otherwise, microarray is the test of choice, and this is what should be offered, irrespective of the type of cardiac defect. Next slide. I think we'll go to the third case first. Yeah, Dr.
Right. So here you can see a third-degree consanguineously married couple who were referred to us in their 5th pregnancy in view of an ultrasound scan showing high drops and IUD, very non-specific phenotype. They also had like 2 miscarriages, couple of blighted, 1 miscarriage, 2 blighted ovums, and at 23 weeks they had an IUD also. They came to us for autopsy, and in the autopsy you could see that there was some prominent very mild dysmorphism, so prominent supraorbital ridge, mild hypertelorism, broad nose, upturned tip of nose, anteverted nares, and some micrognathia. There was a large cystic hygroma in the neck, so you can see it was extending from occiput to the lumbar region. And there was also subcutaneous edema and some pleural effusion. There was also, the hand showed brachydactyly and some 5th finger clinodactyly. So all these are quite non-specific. Then we went ahead, did internal examination. Internal examination was, in the cardiac examination only, we found some defects. So heart showed this rudimentary right ventricle, as you can see there, and the pulmonary artery was around 1 mm in diameter, and the aorta was around 2 mm in diameter. And since the fetus is very small, pulmonary valve leaflets could not be visualized. This was done around 4 14 weeks of gestation. So it was very small fetus, and we were not able to make that out. So communication between pulmonary artery and right ventricle could not be established. So we had a diagnosis of possible pulmonary atresia with valvular pulmonary stenosis. Then you can see in this next slide, you can see a small nubbin-like tissue was seen on the surface of the right ventricle, which was not communicating with the cavity. And this was suspected to be the developing right heart, which had not completely developed. The rest of the structures were all normal in orientation. The trachea, esophagus, they were normal. And so we had a diagnosis of fetal hydrops with a cardiac anomaly, which is hypoplastic right ventricle with an outflow tract defect and some non-specific facial dysmorphism. So chromosomal microarray was ordered. Chromosomal microarray was normal. Then we went ahead and did whole exome sequencing. So in whole exome sequencing, we picked up this particular variant, which is a homozygous variant within the PLD1 gene. And this PLD1 gene defects were known to cause cardiac valvular defects, developmental cardiac valvular defects. When they further went into what actually the valvular defects are, and we also tested the parents, we saw that both parents were heterozygous for this variant. And we also did something known as, we also checked the coverage. So the first picture is about that. We do an IGV, integrated genome viewer, and we check whether coverage is normal or not. And then we check up in a lot of databases. So this is the first four other population databases, first 5 other population databases, where we see that it is not present in certain percentage of normal population or not. And then we go ahead and do a disease database testing, and we see whether this previous variant was reported previously. This variant was reported previously in any other case scenarios or not. We also do a literature search and what is known about PLD1 variants, what kind of phenotype that it will present with. We also do something called as in silico prediction, where we see whether exactly the structural, the conservation and structural variation are affected within this particular variant defect or this particular exact mutation, whether they affect that or not. So that is kind of the whole workup that goes into understanding this NGS data, which is a lot of data because you get so many variants in them and then you have to filter out properly. So in this case, because we had a good phenotype of a right cardiac defect, and that was kind of an isolated anomaly without much things, and this was known to cause fetal hydrops, the presentation of this particular fetus and actually doing the autopsy and diagnosing this helped us to pick up this variant, which is a very rare variant, and that would have been missed otherwise. So that is the importance of actual autopsy and proper phenotyping, and then going ahead with these high throughput tests, especially when we're doing it. So this is a homozygous PLD1 mutation, is previously known to be associated with right-sided cardiac defect, especially pulmonary atresia and stenosis, hypoplastic right heart, tricuspid atresia and VSD. This was consistent with our fetal phenotype, so we made a diagnosis in this case.
Thanks, Dr. Priya. So I think one important question which probably everybody would have in mind, that like, how did you decide that you wanted to do exome sequencing in this case? And then should you have done exome, suppose the autopsy was not done, how did doing the autopsy help? Like, should it have been done on basis of scan findings? So how does all this kind of come together? Just briefly tell us. Yeah. Okay.
Right. So the presentation, which was like the dysmorphism, history of previous multiple losses, that's previous IUDs and multiple early pregnancy losses, and the pedigree, which was strongly suggestive of an autosomal recessive inheritance, that's the 3rd degree consanguinity was present in them. So because of all these features, we thought we could pick up something in exome sequencing. And because of that, we did an exome sequencing in this case. The second question as to would you have done exome sequencing on the basis of USG alone? We had a very non-specific fetal phenotype of a fetal hydrops. Now, based on that, even if you do an exome sequencing, not much of, so it's very difficult in that maze of variants that come in to exactly come to a diagnosis of the variant that we are looking for. So it is a very, very difficult analysis when it becomes like that. So because of that, based on USG alone, we would not have recommended the exome sequencing. And here autopsy gave us a lot of like the exact cardiac anomaly which was present, helped us to correlate with the features or phenotypic features of a previously reported cases on this variant. And because of that, we were able to make the diagnosis of exome sequencing. Now, it will
I
change.
think the important, yeah, the important message here being that even if the family decides to terminate the pregnancy, it's important to encourage them for an autopsy to save the sample of the fetus, blood sample or a cord tissue or a skin biopsy sample, so that all these tests can be done and it really changes the subsequent counseling and subsequent pregnancy management. So in this couple also, like because this is now an autosomal recessive condition, so we can now counsel them. There's a 25% recurrence risk, and because this is causing very early pregnancy losses, so we could even, they have now the option of pre-implantation genetic testing also available once we have a molecular diagnosis. So going all the way is really important, despite the fact that the couple is deciding to terminate the pregnancy. And I think that's the main message from this case. So just to, because this is a little bit of a new thing, so we are all familiar with microarray, and I mean, everybody is, many fetal medicine colleagues are of course now ordering microarray, but the new kid on the block is basically now this exome sequencing. So what we need to realize, and what I initially also said, that single gene disorders are also a very important category of genetic diseases, and they do present with cardiac defect antenatally. There are more than 200 single gene disorders known to present with cardiac defects. Next slide. So many of them are isolated, so we don't worry about these. Maximum these would have a recurrence risk implication, but does not change the management prognosis of the baby. But next slide. But there are many syndromes which present with cardiac disease antenatally, Noonan syndrome being the commonest one. And then Alagille syndrome is another one where you have pulmonary stenosis, and there are so many others. So these are the ones which we don't want to miss, because they have intellectual disability and they also have very high recurrence risk. So that's why now exome sequencing is something which is also important to be included in the genetic testing toolkit. Next slide. There are now this emerging data which is saying that 10 to 20% of prenatally diagnosed congenital heart disease is actually a single gene disorder, and this baby would have more problems postnatally. So it's very important that we should also start thinking about testing beyond chromosomal microarray. But this kind of testing is very complicated, as Dr. Priya explained. So it's important to realize that we should take our genetic colleagues, basically you should consult them before ordering such kind of high throughput tests, and focus on doing these tests probably in patients where you are seeing congenital heart defect with other findings, or you have a positive family history, consanguinity. So choose the cases intelligently, which case you really want to offer these tests upfront or as a second tier test. So all these things is very important, and please stick to doing a clinical exome sequencing. Don't do whole exome sequencing, whole genome sequencing. These are all research tests. They should not be done for clinical diagnostics. Next slide, Dr. Priya. So there are guidelines available on when to use exome sequencing in prenatal scenarios. So you can go through this document. Next slide. So I would just like to summarize by saying that whenever you have a prenatally detected congenital heart defect, please do as a minimum a chromosomal microarray if the patient is able to afford, or at least a karyotype and a diGERT study. But then, because there are of course association with single gene disorders, so now again exome sequencing should also come in your diagnostic algorithm. And then the other very important point is that even if the family terminates the pregnancy, please encourage them to do an autopsy, encourage them to collect a sample so that we can do a genetic testing which can help them for their next conceptions. So, I mean, doing the genetic testing again is important both prenatally for prognostication and also subsequently for recurrence risk counseling. So that's the main thing which basically we wanted to highlight through these cases. And some other scenarios which you should think of genetic evaluations are fetal arrhythmias, even unexplained fetal demise. Around 10% of these could be long QT syndromes, and rhabdomyomas. A very high percentage are basically tuberous sclerosis and the various cardiomyopathies. So these are again situations where we should think of genetic testing. I think we just end this session, I mean, from our side. And Praveen sir, I would like you to please summarize and give your expert comments.
Thank you, Shagun. And then congratulations, Priya Ranganath. You have done a great job. And actually, the choosing of the cases were very, very appropriate in the sense you choose one trisomy, you choose one microdeletion, you choose one syndromic cardiac abnormality. I mean, these are the typical presentations that we expect in our day-to-day practice. And you made it very clear that what to do and when to do and how to go about these things. Actually, the American Heart Association, particularly in the circulation research, they have published one flow chart. It is very interesting, and I think it is published in 2017, circulation research, in which they have taken into consideration the cardiac defect and extracardiac abnormalities, family history, pedigree drawing, and then based on that, when there is a high suspicion of trisomy, they suggested that we need to go ahead with do a karyotyping in fish. In case whenever you are having a high suspicion of duplication, then fish. And if that turns out to be negative, then we need to do a chromosomal microarray. And particularly when we have a high suspicion of associated syndromic condition, in that situation, we need to do a whole exome sequencing. I think this is the flowchart that they have published. And I think this is a very useful flowchart in the sense because in our practice, quite often you do come across, suppose you come across a conotruncal abnormality. We need to know what exactly to suggest the patient and where to go on and how to take them ahead. So I think this is one thing which is going to, and then I'm sure genetics in cardiac abnormalities is going to go a big way. And as you know, even though it's a very heavy subject, still you find that there are almost about 167 delegates hanging around. So it shows that this is catching up. So genetics is a part of our life. I think we have to be with it. And that is one of the expectations and the improvements that we have to show come forward. Thank you very much, and congratulations once again for the wonderful presentations.
Thank you, sir. Dr. Priya, you can stop sharing your screen now.
Yeah,
Over
Dr.
to Ashok Khurana, sir, for the audience interaction.
Yeah, Dr. Chinmay,
Yes.
I'll just take the liberty of, okay, Priya has removed this.
Yes,
I just wanted to tell about that we have a prenatal genetics fellowship for our SFM colleagues. So this is basically for our fetal medicine colleagues, and this fellowship is under the Society of Indian Academy of Medical Genetics. So if any of you are interested to know more about genetics and how it's relevant for fetal medicine practice, you're most welcome. All the information is available on SFM website, so you could go through that. Thank you. Priya, you can stop the screen sharing.
But good evening, everyone. And of course, this has been an absolute treat. It's a program which I thought was hurriedly put together. It doesn't look like a program that was hurriedly put together. This is a very well worked out program. It's excellent. We started with this fabulous combination of grassroots glamour that I call the trademark of Bimal Sani. He has the most brilliant way of bringing glamour down to earth and putting it into our everyday lives and making sure that our patients get the best of it. It used to have very elitist appeal once upon a time, but he has really made sure that everybody on the street can now have this, which is fantastic. And I truly look forward to the next few years under his leadership, taking over from Dr. TL and Praveen, who has set the classic shadow of maturity on the Society of Fetal Medicine, where we've come to be a large international society today. Moving on to the questions, we've had really a lot of questions answered already, but there are some very, very basic questions that have been asked that we need a few more answers on, some which are directly, just single rapid answers. So the very simple question was one asked right at the end by Dr. Gajavali. Why is QFPCR preferred over FISH in rapid diagnosis? So Shagun can perhaps answer that for us.
So, I mean, actually, either of the tests are good enough. It's just about which lab, what your lab is comfortable with. So fish is little bit laborious and it is more expensive. QFPCR is little cheaper. It is automated. You don't. It can be just, I mean, done very fast. Also, and also without having a very specific trained person. Like for fish, you need one person who will be really trained for years, and that person only can do that. For QFPCR, you can train anybody, and it becomes an automated test. So it's just a more recent technique, but both are good enough in performance. So whatever is available, do it.
Is this a DNA based one?
Yes, yes, yes. It's a DNA based test.
Excellent. The second rapid fire question is in a cardiac rhabdomyoma, and I know this was on your slide. What genetic testing is advised for TSC1 and TSC2 mutation?
So basically, these are actually very large genes. So for large genes, we would need to go for an NGS-based testing. So either you can do a clinical exome or you can do a multi-gene panel, whereby these two genes are covered in that panel. But these are huge genes, so we cannot test them using the conventional Sanger sequencing. So we have to do next generation sequencing for this. Yes,
can we, for this TSC1, TSC2, do you think that the targeted sequencing can be, suppose you do an ultrasound examination, you find a rhabdomyoma, you find a tumor in the brain, and can we do a targeted sequencing for that?
So, I mean, targeted sequencing actually for these two genes, the targeted sequencing, the usual technique is Sanger sequencing. So for Sanger sequencing, if you have a very big gene means if there are multiple exons of the gene, then that Sanger sequencing will turn out to be more expensive, more time consuming than doing a next generation sequencing. So if for larger genes, we directly go for next generation sequencing. If it is a small gene or a single mutation, like in achondroplasia. So if you have achondroplasia, 95% patients have one mutation. So you just need a simple Sanger sequencing or a
simple. So how do you go about this de novo mutations? In this de novo mutations of tuberous sclerosis?
De novo mutations. So we can, I mean, by doing NGS, you can, I mean, we can pick up the de novo, I mean, we can pick up the mutation. Then in parents, we can use conventional sequencing to see whether they have the same mutation or not. Parents, we don't need to do NGS. Once we have identified the mutation, we can use simple PCR-based test to check the parents and see whether it is de novo or not.
Wonderful. And we go on to our next question. And this is truly something we face every day. So we have a couple. They've had a history of termination of pregnancy due to some cardiac malformation with no reports available, no workup done in the past, and now she's pregnant again, and she arrives at 14 and a half weeks of gestation. What can I offer this couple apart from my Roth?
So we would we'd start with basic karyotype. I mean, for both the partners, one of them could be having a balanced translocation, and that could have caused a chromosomal abnormality in the baby and resulted in the cardiac defect. So that is the basic test. But then with the cardiac defect, now that she's already pregnant, so we don't have time to do one test to second test to third test. So upfront, I would offer her even a 22q deletion for both the partners. Because as we saw in that case, you could have asymptomatic, healthy looking parents, but carrying a 22q deletion, and tomorrow they would have another baby with a cardiac defect. So both karyotype and 22q deletion to be done upfront. Then again, the role comes of exome sequencing. So here, if the couple is consanguineous or in that with that cardiac defect, there was some other syndromic feature which we can make out either by scan, or if sometimes the couples are now carrying the photographs of fetuses, aborted fetuses in their phones or babies in their phones. So once we look at that, we can make out the dysmorphology, and we can sometimes make a spot diagnosis of a genetic syndrome. And if it is looking like a single gene disorder, then in that case, so basically what Dr. Bimal was saying, the pattern recognition. So recognize the pattern, recognize the dysmorphology, see the pedigree. Is it consanguinity? Are there more than one baby with a cardiac malformation? So if there are some indicator that this could be a single gene disorder related cardiac defect, then I would also do a clinical exome sequencing for the couple to look whether they are carriers of a condition which is resulting in cardiac defect. So we would do everything actually for them, if depending on the situation, of course, but yes.
Yes, thanks for starting this at the right point and taking it to the right point. The next question I want to translate. There's a question from Sushma Meda that says, can you explain what cardiac defects are frequently associated with genetic disorders? And I want to put this differently in 3 different scenarios. I have an isolated muscular VSD, 7 millimeters. I have a tetralogy of Fallot, and I have all the other defects. So which of these deserves genetic attention, and where can I get away without giving genetic attention?
So all deserve genetic attention.
True.
All
So,
deserve.
this is what I want you to drive home as a point, that in today's day and age, knowing that ultrasound will not pick up everything, knowing that I might miss 3 small VSDs when I picked up a 7 millimeter VSD, and knowing fully well that TGA now has defined one association at least, should I ever exclude genetic evaluation or at least a genetic counseling for anybody in whom I find something?
No.
Every case deserves it, sir. It should be done because we don't know what else the baby has. I mean, besides the cardiac thing.
Absolutely true.
So
And
it's
we've
really
seen how
important.
much ultrasound may not reveal and a autopsy might reveal. So obviously we cannot use that as the gold standard for guiding us.
Yes.
Which brings me to the next question. And that question is that we had a nice, good old-fashioned NIPT that we used to use, and for 22q11, and it said that the SNP based NIPT detects fetal 22q11 with a sensitivity of 97.8 and a false positive rate of about 0.7, whatever. However, they've now changed the technique, and the number of targeted SNPs has gone up from about 600 odd to 1300 odd, and the user threshold of 0.90 and 0.95 to 0.95, and the reflex sequence of high-risk calls at higher depth was implemented. Now, how much sense does this make in terms of the fact that I should always, in my patient who refuses invasive testing, try and do an NIPT instead? And the second half of the question, when I do NIPT for my routine patients at 12 weeks of gestation, should I now add, in addition to my common autosomal trisomies and no findings on the ultrasound, is it time for me to add my NIPT for 22q11?
So, so these are very complicated questions.
Yes, but
No, there are no clear answers actually.
The market is coming at us. Yes, the market is coming at us. We've been able to squeeze them around a few years ago and say, look, you cannot bypass us. Cannot bypass the medical profession and the genetic setups. You have to go through us. So today they say, no, I have this NIPT, which is like 97, 98, because I've done ABCD, which you will never understand because the words are too complicated. But the fact is the market is there. The fact is that they brought down their price to like 5,000 rupees. And my patient says, I am going to do it. What do I say? What do I do? And should I just offer it to anybody who can afford it?
So one thing is that the NIPT sensitivity for microdeletion, the company may be saying 97%,
Yes.
but then there are certain atypical deletions actually.
Yes.
Not all patients will have the typical 22q deletion. So this is like little bit of intricacy of genetics, but there are smaller deletions of the 22q deletion region, which will not get picked up by the NIPT. So what they are saying 97% is for the typical deletion. So this is something which they will not tell. So I would not use NIPT to screen my patient for Dijot syndrome. At present, at least I'm not doing. We are not offering it to our patients.
So
we are just using it for screening.
We need more evidence before we start using it routinely.
Yes.
And now I have this patient who has IVF and a 3 millimeter VSD, no other finding. And she says, can you do something for me, please, on my blood? And in addition to NIPT, can I do something more like that? What do I say to her?
Yes, sir. I guess maybe on this situation, we offer her both the things. We tell her that, okay, we have this non-invasive test available. This is the sensitivity, but we could miss something, and then we have the invasive test available. But then the catch is that the NIPT is going to just tell some diseases. Correct. It is just going to tell us the trisomies. It is just going to tell us 22q deletion. but it will miss some other genetic conditions. So this risk we have to tell her. So the patient has to basically balance between doing an invasive test, which will give her much more information, more definitive information, but the risk versus doing NIPT, at least checking for the main things and not taking a risk. So I don't think we can decide this for the patient. This is something which has to be conveyed, and they only have to take the call. I know it's very difficult. Often the patients will finally just ask you, Madam, please tell, what do you want what do you want us to do? Because it's very difficult for anybody to understand, actually. I mean, even despite counseling, the patients are, I mean, I feel sad for them, but they really are really confused, and it's very tough, actually.
But we have to give
For
them
them
the
to-
options, and then we let them
Yes.
decide. Yes.
Yes,
So
yes.
moving on to some of our structural questions, and I want inputs from both Dr. Bimal Sani and Dr. Nitin Rao for this. Bimal, what do you feel? Is there anything as fetal echo, which is part and parcel of anomaly scan? And a second question, is it justified to charge extra for the same? What part of cardiac evaluation comes in an anomaly scan, and what is the addition in a fetal echo, and how do we draw these lines?
As a part of our anomaly scan, uh, we actually are doing the extended basic examination, sir. We are looking at the 4-chamber view, the outflow tract, the 3-vessel view, and the 3-vessel tracheal view with color. Now, very honestly speaking, as people are becoming more and more experienced and all, so your basic extended basic evaluation is as good as a fetal echo these days, because the moment you see something, you are definitely extend. It's not that key. If I see asymmetry, I'm going to leave it for suggest a fetal echo, call the patient again and do it. So so it is a part. So you are as good as doing a fetal echo, but if fetal echo as an entity, because of other indications, is along with these things, then everything else comes in. Because if you ask Dr. Nitin Rao, he would add more to what we do at the moment also, because they would want much more information. But then everything, all the Z scores, the biometry, your external, your other views, the longitudinal arch views, the bicaval, the ductus venosus, then all these things would actually come as a part of the fetal echo. And that is the reason the charges of your basic anomaly scan should be high, because you are as good as doing everything that time.
Wonderful. Dr. Nitin Rao, your inputs, please.
Yeah, I agree that the cardiac evaluation becomes part of the anomaly scan. There's there, and but like Dr. Bimal said, when you have some more to see, or when there's some counseling required, it's always, and it's like one of the things. Sometimes you have something called like a D or a double outlet right ventricle, where you have malposed great arteries, and you think it's different, but actually some of this, the one of them called toxic being anomaly, that's also with severe coarctation, that can be really missed. And that can be, if you just see a VHG and double R, you might think it's okay, but that can have prenatal, you need prostaglandin, you need a lot of stuff, they can crash after birth. So those small things need to be seen. And especially when it comes to counseling, getting the surgeon involved, we get involved. But anomalies can usually, most of them do pick up most of the cardiac stuff. So it's very rare.
Which takes us to our next question. Do you think that our patients, by the time they reach you for attention, have been incorrectly counseled and guided?
Yeah, some of them are, especially especially the family is not very keen on doing it. There's a lot of ignorance going on there. Some of them we counsel very badly, but some of them they go proper center, they get quite good counseling. And one thing is, suppose it's a high risk pregnancy, bad obstetric history, or an IVF patient, they are more open to discussion. They are more open to discuss with us. They are more open to listen to us than someone who's a first baby. These sort of cases who are counseled well, they are quite okay.
Thank you for
First
that.
counselors are the doctor in the family. They are the most important counselors for them, and they may be anything, right from a surgeon to a BAMS or anything. He's the most important person, and when they counsel, they really do it very bad because they hardly know anything about it.
Right.
So I think you need to counsel them first.
Yeah. And in fact, now it's less, but earlier we used to get a lot of referrals for ecogenic endocardiac focus, and there was a lot of tension, a lot of adrenaline. So it's some chromosomal anomalies, but it took a lot of counseling. It's now come down now, but we still see that for simple things. Yeah.
Thank you. And Bimal, in your opinion, when it comes to this kind of a counseling, when we discover it on an ultrasound scan, that gone are the days when the obstetrician used to tell us don't counsel. They expect us to counsel, and then they say, okay, go right ahead and introduce the whole topic. So, do you think we should do it as part of while I'm talking and studying, or you think it should be part of a separate session at a different time of the day? Or should we always just say, look, let me get together with my clinical colleagues and have a Zoom meeting or a panel kind of a thing, like a cancer board, we have a cardiac anomaly board.
The third one is the best option, but then, in real life, it becomes difficult because getting all these things done, especially in areas like ours, where most of the patients come from outside the city, they would be, they don't give you that much of time to do all this. So, of course, idealistic, that is the best, having a multidisciplinary counseling. But otherwise, I think the second option is what is practical, where you finish the scan and then you tell them, go have your lunch or have your coffee and then come back. And as a separate session, and that actually that time gives, that much of time that you get, it gives you a chance to, Google search yourself at times, because when you're counseling, patients are going to ask you statistics and all those things. So it's always better to review before you do it. If like at times I call my pediatric cardiologist for a few opinions before talking to the patient. And that is important because see, you can't finish up the scan, give the report and tell them that go and meet a pediatric cardiologist. They'll say, okay, why? But you'll say, okay, there is an anomaly. Then they'll say, okay, what it is? Is it bad? Is it lethal? Now, see, eventually you have to, you just can't shut them off and say, okay, this is your report. Now you go ahead and all. So do it as a separate session. You definitely never at the time of the scan. So get the patient, look at the, because it gives you some time to evaluate the sensibility of the family also, what is their understanding level also. So that way you can explain it to them.
Yeah, thanks. We are a little pressed for time, but let me just say we will not accept any more questions except to answer some ones that have come in. And the first one is, there is evidence to suggest that from the Italian groups that a cardiac defect results in abnormal fetal brain modeling and neurologic deficits in the first 2 years of life, which include cognition defects. Where are we to include this, which is now a 6-year-old finding and repeatedly shown in European literature? Where do we include this in our counseling?
Which one?
Dario Palladini and his group and several others said that, look, the presence of a cardiac defect can be
also associated with
brain development.
Neurodevelopmental abnormality.
Yes. So should we just throw this in every patient's face and say, look, there's no hope for you?
No, I mean, that way you are going to increase the anxiety of the parents. But of course, we need to give them the information.
Yeah.
Saying that probably.
Here, actually, what we do is we get the cardiologist in every week once, and we know that that is the cardiology clinic. And any of these cases which are prenatally diagnosed cardiac anomalies or even suspicions or previous cardiac anomalies, they meet the cardiologist and they give them the local data outcomes. Like for us, Dr. Nitin Rao comes over. So the last 5 years, whatever surgeries they've had, last 15 years, whatever surgeries they've had, they have a follow-up of their own patients. And at least at the local level, that outcome can be given to them. Because like you said, the moment you say that this can be associated with, they're already dealing with one trauma, that there is a cardiac defect. And the moment we say that even if we correct the cardiac defect, there could be other issues in the background, it is very unnerving for them, for a child which is not yet born. So tempering this information by giving local data and sometimes meeting up with families who've had correction for cardiac defects in the past helps. So that's what we have done at a local unit level.
That's not the evidence, isn't it? Present evidence, when it is there that there is a possibility of a 2-year neurodevelopmental delay.
There is a possibility for sure,
then
sir.
we cannot
True.
ignore that, you know.
No, we won't ignore it, but we can say that there is a possibility. But
Yeah,
again, the
once you say that,
possibility is
that is
also
unwavering.
the possibility is also multifactorial, whether it is because of, hypoxic damage during the pregnancy, or at the time of, perinatal management, or at the time of surgery, or at the time of follow-up. And once all these things have been optimized, there is still a possibility of having a neurologically intact child is also an information which we can give them.
Wonderful.
Yeah, complex heart is there is risk is there, but that has to be told. Yeah, that's there. We must.
So our last question, we now have encouraging news that Kerala for the last 3-4 years is now the government is completely supporting free cardiac surgery. We also have news that we have 2 voluntary agencies in New Delhi and one in the Northeast for supporting the complete cost of cardiac surgery. So who is going to take the lead and put
No, sir.
together?
In Telangana also we have, I think Dr. Nitin Rao will tell us, we have an Arogyashri program, and they themselves, the cardiac team themselves, has actually helped us raise funds for some of our cases. I think, Dr. Nitin, you should give us the final word on this.
You could tell us the background and how we go about this.
We have a scheme called Arogyashri scheme where they enroll with the BPL card and gets help from the government. They pay quite less actually, not too much, but still it helps to some extent. So we have a funding agency that helps us to give to gap funding. Otherwise, with Arogyashri scheme, it's impossible. That's how we managed to arrange funds. Now there are other people also managed to raise funds. It's not fully 100% free, but they give some amount of money, and we get some from charities. But the government that pays presently is quite less, so we have to have some gap funding. It's not like 100% free in Kerala, but it to great extent mitigates the expense to some extent.
So, Chinmay, who on your team is going to put together a list of agencies all over the country, and then we put it on our SFM website?
We'll start working on
Could the
that.
Telangana chapter put that together, and then we could share it at the national level? And or you can just get inputs from all of us. We could put it on our WhatsApp groups and the Telegram groups, and then we could go right ahead.
Yes.
And just one thing, because we had one patient who came in from Maharashtra, had a TGA, came to us on day 10 of life, very enthusiastic. The family went off very well, but it had quite a prolonged course. And then we did social funding, and we got quite a few funds from Keto. That also helps us. Keto Milak helps us. And through Keto, I got some of my friends in the US, they got, because child had a bill of almost 10 lakhs. But it came up through social media, we managed to raise some money. That's
Excellent. That's really nice. Yeah. Well, that brings us to the end of questions. We have lots and lots of questions sitting in the chat box, which are similar. One including who should be doing the counseling, and I think we've answered that we can't be strict because we don't have such a formal setup that is universally available. In fact, it's not available really in many centers in the world. There are very few centers in the world that have centralized counseling, etc., etc. And our patients with our Indian mindset will certainly go mad if they have to wait more than a few hours to be counseled appropriately. So we have to start somewhere. So we have to develop our own methods. So with that, I guess I want to congratulate this entire Telangana chapter for putting together this absolutely brilliant program in no time. Our expectations are very high. You're going to have to live up to them. And I'm so glad we had Dr. Nitin Rao with us to give us the perspective from what I call the other side. I think if we have these kind of multi-specialty panels, they will really help us in taking our messages forward. We've had a fantastic attendance today. We had over 280 at peak time, and our average attendance, which is some fancy mathematical calculation, has been 204 at all times, which I think is phenomenal for a local program. We've had a huge local representation, which I think is fantastic. We've had over 24 foreign registrations over here from overseas, and it speaks millions for the choice of such a fantastic program. My congratulations to everyone on the team for bringing such a fantastic program to us.
Thank you so much, sir. Thank you. It's all your inspiration, and we just follow footsteps there. So we'll try our best to keep justify your expectations, sir. And before we finish, if you would allow Dr. Sahiti Reddy to just give off the vote of thanks.
It is my privilege to present the vote of thanks in the first academic webinar of SFM Telangana. I thank the founder and mentor of SFM, Professor Ashok Khurana sir, for giving the opportunity, and we are grateful for our seniors for always encouraging us. I thank all the senior faculty, Dr. Bimal Sahani sir, President-elect of SFM, Dr. TLN Praveen sir, President of SFM, Dr. Geeta Kolar ma'am, Dr. Narasimha Reddy sir, Dr. Nitin Rao sir, Dr. Chinmay ma'am, and Dr. Shagun Agarwal ma'am, along with the younger faculty members, Dr. Pranhita and Dr. Priya Ranganath. I myself was excited about this opportunity to present my case in today's webinar. I also thank Mr. Vishal Mittal from the SFM Central Office for seamless coordination at all the times. I thank Lifestyle International and Conference International for the logistics support. Finally, I thank all our very attentive and interactive audience who have made this effort worthwhile for us. Thank you very much, everyone. We will see you again on 20th April for the next session. Good night.
Thank you. Thank you, Chinmay. Thank you so much.
Thank you very much, sir.
Very
Thank
much.
you, everybody, for joining in.
Thank you.
Very good case.
Good night. Good night.
Thank you, Bimal sir. Thank you.